Thanks everybody for jumping on tonight, and special thanks to Ben, Kelly, and Eric for putting this together and working hard with me on the presentation. So today's goal for me is really to go through, my experience with this, with the TendoNova procedure and device, and really talk about how I use this in my practice as part of my toolbox for getting the job done with a lot of these chronic tendinopathy patients. My experience, or my background, I could say I work in Orlando. I've been at Orlando Health for about 5 years now. Little background about me. I previously had worked in Tampa, and I did most of my training in Florida. Undergraduate, I grew up in New York State, so I went to University of Buffalo for undergraduate and moved down to Florida for medical school, stayed for family medicine residency, and then did a sports fellowship at Wake Forest. Came back down to Florida, practiced in Tampa for a little bit, and then jumped over to Orlando. And my main day-to-day responsibilities involve taking care of a lot of different athletes and locals here in Orlando. I am our fellowship director for our primary care sports fellowship program, which we take 2 fellows per year. I'm also team physician for our MLS club here in Orlando, which is Orlando City, our NWSL club, which is Orlando Pride, and I'm also team physician for USA Track and Field, the Orlando-based athletes, which we have about 20 to 30 or so athletes of that variety. And then I am the medical director for the PGA event that comes through town, and I also consult for LPGA and the PGA. So I have a lot of fun things to do outside of just my clinic duties, but primarily my experience kind of spans between professional, collegiate, and um, normal folks. I don't have any disclosures for this talk. I will say, I just want to, make it clear that I use TendoNova in my practice, but I do a variety of different things. This is a background of what I do. I use a lot of different modalities to treat chronic tendinopathy. I've been using PRP for years. I do prolotherapy. I've used 10x and continue to use 10x, and I used TendoNova over the last year or so. I've been really happy with adding that to my practice. And as part of sports medicine practice, where we see pretty much all ages, upwards of 10 years old. I had a patient who was 100 a couple weeks ago. So, the fun is seeing all different varieties and using all these different modalities on different types of athletes, whether that's professional, collegiate, scholastic, weekend warriors, the masters athlete, as we call them. And so I think my experience with this device has been really great, and I'm happy to share with you how I use it. So when I'm managing tendinopathy, and I'm sure many of you have experience with this, the idea is figuring out what exactly the problem is. There's a lot of times where we're trying to identify what the cause is and the time frame of what stage we're in. Are we in a tendinitis phase? Are we in a tendinosis phase? Are we in a calcific tendinopathy phase? Are we coming out of those phases? And how exactly are we going to best, treat our patients to get them out of that? As many of you know, sometimes it's easier to just deal with an acute, broken bone or muscle tear, ligament tear, than it is to deal with chronic tendinopathy, because it could just last so long. And that cycle of pain and inflammation is so challenging to manage. So anything, a few years ago, I wasn't, well, I should say not maybe a few years ago, but when I was coming out of fellowship, I really didn't have any of these types of tendon procedures in my toolbox yet, aside from PRP. And most of us go through the typical gamut of NSAIDs, physical therapy. What type of injections are we going to do? Cortisone or plasma or whatnot? Do we refer them to surgery? Do we not? What do you do with these chronic tendinopathies? But I've really found a lot of success with this TendoNova procedure, and just the ability to be super precise and efficient with it has helped a lot of my patients. And as I've done more and more of these and see more patients in the follow-up phase, you really get to see the magic behind it, because when patients come back and they're 3 months out and they're completely resolved, it's really, really neat. So I hope you would consider this in your toolbox of tricks to kind of manage these patients. It's pretty debilitating for them. I think a really important part of choosing TendoNova and using it is when we select to use it and on whom. I think that age certainly is a factor. I think young patients tend to do better, but I have had great success with older patients as well. But considering what exactly we're working with, the condition of the tendon, and the general idea of like how well somebody is going to heal from a procedure. The way I typically start when I'm dealing with a chronic tendinopathy is I manage it conservatively. And when they don't respond to the standard stuff, rest, NSAIDs, activity modifications, physical therapy, then I start getting some advanced imaging, and I really try to hone in on what exactly the condition of that tendon is. Are we just inflamed? Are we in a chronic tendinopathy phase? Are we starting to get some calcific buildup? Is there some interstitial tearing developing? And when I can start honing in on that, I can be a little bit more precise in how I decide what we're going to do next. And that's where I think the TendoNova has it really shines for me, because I use that in patients where before I was afraid of doing a 10X, or I was afraid of doing something else, or maybe I was being too conservative. We always consider with our patients too what exactly we need to get out of our recovery. When you take care of a lot of active people and athletes, the first question everybody always asks is, when can I go back to work, or when can I go back to play? And I think with TendoNova, this procedure really allows people to get back relatively quickly compared to some of the other modalities that are out there, but definitely faster than surgery. But even sometimes with some of the 10X stuff that I do, I see them get back a little faster because it's just a little bit more delicate. And then, I decide how I want to manage these tendons. Am I going to do plasma? Am I going to do TendoNova? Am I going to use 10X? Am I going to do Prolo? Am I going to do some sort of combination? I have a lot of success with using the TendoNova and putting PRP with it. So patients for years that I was just doing PRP, by adding the TendoNova, I found a lot more success in getting them better faster because of kind of coupling those two. And then rehabilitation. I think there is actually a really strong place for rehabilitating patients before procedures and getting their body optimized and working on biomechanics. I always tell my patients that if we don't figure out the reason why you develop this tendonitis, even if we fix it and it goes away, at some point it can come back. So we always have to work on the answering the why question. Why did you develop Achilles tendonitis? Why do you have plantar fasciitis? And most of those answers come when I send them to physical therapy with a skilled therapist, and they can figure out, okay, yeah, this is exactly what our issue is biomechanically, and we start addressing that, before and after the procedure. So TendoNova is a really great tool. So the way I think of it is the TendoNova device, uses a cutting action basically to introduce a micro trauma to a tendon. So when we deal with a chronic tendinopathy, we're in this vicious cycle of chronic disorganization, collagen disrepair, and it's just going round and around. And we try to break that chronic cycle and turn it into an acute injury, not a major injury, but an acute, micro trauma injury that really stimulates healing and almost like starting from scratch. And I use it to debride some of those bad areas of tendon to introduce a little bit of bleeding, introduce a little bit of, kind of pro-inflammatory environment on purpose, in a controlled way that's actually going to help us start that healing process. So that's what's really neat about the TendoNova device. And because it's so subtle and it's so efficient, I can get through the tissue very, very smoothly and not worry about damaging too many other things, as long as I'm really careful and paying attention to what I'm doing. And I can hone in on just the problem area itself, just the very specific problem area. So I can be really, really, precise with how I do that. The procedure itself, for those of you who aren't familiar with the device, this is what it looks like. It's really easy to hold and easy to set up. There's no wires or anything like that involved. I do a lot of 10X procedures as well, and that involves a whole lot of different complicated setup. So this is definitely easier. And you don't have to do any incision, which is really nice. You just kind of poke right through the skin percutaneously. And because of that, you're able to make multiple entry points if you need to. So areas where I've had very involvement of multiple tendons, or a really large area on the Achilles where I have to get to in the medial lateral aspects, I can just make multiple entry points without introducing too much trauma to the tendon, which is really nice because the needle is so subtle and so efficient. So that's nice. It also has a little bit of flexibility to it. So that bend allows me to kind of curve it a little bit or get to areas that I want to and be really, really, specific with how I introduce the cutting, um, which is great. This is typically how I set up my procedures. This is kind of just what the tray looks like. You have the TendoNova device, and we have just some ChloraPrep, some lidocaine, ultrasound gel, and the sterile setup, and that's really all you need. Ultrasound probe cover, and this goes super smoothly. The setup is super easy. It's uncomplicated. The staff that sets this up either in the operating room, or we have a procedure room in our surgery center. It's really simple for them. So they like it. They're usually really happy when they know we have a TendoNova case, because it's going to be such an easy setup and takedown. And we can do a lot more procedures. Just a quick video, like the action of the needle tip here. So, that tip is just kind of going back and forth, making some micro trauma. This is a lateral epicondyle, common extensor tendon origin. And you can kind of see a little damaged area in the middle here. And then, whoever's using this device here, this is just a generic video from the TendoNova website, but you can just see the debridement kind of happening in the middle there. And that's exactly what we do. It could be very, very specific. You just find that bad spot, and that's the area you want to just debride, introduce a little bit of micro trauma, and you're in and out. My cutting time when I'm doing these procedures is very, very short. Comparatively, when I'm doing a 10X procedure, I'll be in there maybe like 3 or 4 minutes of cutting for some areas. With TendoNova, it's much, much less. I mean, probably on average, like 30 seconds to maybe a minute tops, but 30 seconds probably is more like it, because I can just get to where I need, introduce the micro trauma, be very, very specific, and then I'm out. I don't feel like I have to fight the device or fight anything. It's extremely efficient. And we're in and out. The shorter time I'm in there, the less infection risk there is, the happier the patients are, and we're moving onwards. So um, uh, my use for it, I really love it in the elbow world, lateral and medial epicondylitis. I've done both. I like that it's a smaller needle gauge, so I don't have to worry about too much trauma to the tissue. When you look at somebody who's really petite and they have tennis elbow, sometimes you are scanning the tendon, and the size of the needle is just half the size of the tendon. So a big giant larger gauge device is not really necessary. I like how subtle the TendoNova tip is, and it allows me to just get in there very gently and just work on the areas I want to, and then leave all of the healthy stuff, undisturbed. And patients recover faster with that. And I got the job done where I want it to be. So it can be very precise. After I do a lateral or medial epicondyle, I usually put them in a wrist brace and a shoulder sling. The sling for a couple of days just to rest, and then the wrist brace for 2 weeks. And then I like patients to have PT. Sometimes they can't. We'll just do home exercises. And I'll do this procedure with or without PRP. I prefer to do it with PRP, but if the patient can't afford the cash pay of the platelets, then we'll just do it without. I have had, good success with both. But I think, whenever I can add PRP, I'm always trying to, because I do think it just speeds up the overall recovery a little bit for folks. In plantar fascias, I can be super efficient with the TendoNova when I'm working on plantar fascia. And my goal is really to just get partial release of that fascia from the calcaneal tuberosity. So I can make multiple passes and just super efficiently cut through it, which is really, really, really nice, really fast. And there's not a big incision. We just poke through the heel, through the skin. And so that's easy with wound management is really simple for these. I also like the length of the tool, which is nice because if I need to get to the lateral band and I'm coming from a medial approach, most of my patients have central band plantar fasciitis that gets really bad, but if they develop some lateral band issues, I can get all the way across to it without even having to make another entry on the other side. If I do need to make an entry on the other side, which I've had to do before, then it's really subtle because I'll just a little local anesthetic and then poke through with the TendoNova needle and it goes really quickly as opposed to like a different device where you might have to make an incision first. Recovery for that, I just do a walking boot for a couple weeks and then have them do a follow-up with me at 2 weeks to see where we're at. People who aren't too are doing pretty well and they're good with some stretching exercises, we'll just let them be and do things at home. Other folks will do physical therapy. And then works great with PRP, although this one I don't push the PRP as much because my goal again is to just get enough micro trauma to get some release of the plantar fascia there. So I don't necessarily have to do that one with PRP, but if patients are interested and they want it, then it'll help too. So that's great. And then my favorite thing that I've done with the TendoNova for sure has been like how I've changed my practice with gluteal tendinopathy. So, I work in a place where we get a lot of hip patients. We have a lot of folks with hip arthritis. We have a lot of, trochanteric bursitis diagnoses. And most patients with trochanteric bursitis, it's really gluteal tendinopathy that we just call bursitis because of, the ease of the diagnosis. But when you look at them on an MRI or with ultrasound, you'll find the issue is really in the glutes. And these folks, they really need a physical therapy plan to figure out what's going on biomechanically to cause this. They do really well when I prehab them and then do TendoNova. But folks who have like native hips or if they have arthroplasties. We see a lot of gluteal tendinopathy after arthroplasty. Patients who are frustrated with their hip replacements because their hip still hurts and it's really just lateral pain. This has been a major game changer for me with how I treat patients. So previously doing a lot of treatment for the glutes was just PRP or cortisone shots. And then when the cortisone runs out of its magic after a couple, I don't typically do more than 2 shots, then I was progressing to PRP. And for a few years in the early parts of my practice, I tried doing this with TendoNova, with Tenex, I'm sorry, and I just couldn't really get the depth I wanted with the device. So when the TendoNova device kind of came into my world, and I've really enjoyed using that because it's longer, it's a little bit more flexible. I can make easily a couple entry points so I can address the gluteus medius the way I want to, and then pivot and move over to the gluteus minimus. And then on ultrasound, I can just address both tendons and then what I'll do is I'll just twist off the needle and pull the device back and attach the PRP and then flush some PRP in there afterwards. And it just has been amazing. So I've had some awesome success stories. I think the most satisfied patients I've had who like changed their lives with their like chronic lateral hip pain for years has been when I do TendoNova on the glutes. So that's been really helpful. And again, it allows me to be really, really precise. It just allows me to minimize any trauma to areas that don't need it. I don't have to worry about, fat necrosis or unnecessary incisions or wound management or anything like that because we can be so specific and targeted. Achilles tendinopathy has been I really like it for Achilles tendinopathy. Especially mid-substance Achilles. When I'm working on like a nasty heel spur or some calcifications, that sort of thing, I still typically do 10x to grind up some of that bone. But when I am working on just pure tendon at the insertion or in the mid-substance, I really prefer the TendoNova, and I like doing it with PRP, but not everybody can afford it. So even without it, I get good results. I just had a patient back today. We just did her mid-substance Achilles 3 months ago, and she's doing awesome. She's like completely resolved. She's been working well with PT, and she's been doing really good. So that was just, a real life example from today. So these are some pictures of how that looks. You can see that pathologic tendon. It's in that superficial, maybe half or third of the mid-substance there, that darker hypoechoic tendon, as it's heading down towards the calcaneus. And then in the lower right, you can kind of see that TendoNova device, making a pass all the way through there. And I kind of take it all the way down. That first pass, I take it all the way down to that anterior aspect of the peritoneum, and then I back up, and then I just start working all of the tendinopathic area. So that just gives me a little bit of release. It also allows me to put some PRP. It gives me a track for PRP when I want to put it down there near the fat pad or near the retrocalcaneal bursa. So it just gives me a track. But it's also really important to work with physical therapy on these too. I think the best results come when you're working on the therapy component as well. And I really like, again, how subtle the needle is. So the cutting tip is it's so efficient that, in the beginning when I was doing these, it's almost like I had to get used to how fast it would go, because I was used to, other devices where it just took me a while to debride things. But this just allows me to cut extremely fast, extremely efficiently, and then, we're done. I think when I'm teaching my fellows this procedure, I tell them, with the TendoNova, I think less is more. I typically don't need to be in there for minutes. I'm in there for, seconds, 30 seconds probably. And that's all I need. I did what I need to do. I got enough of that micro trauma started, did my debridement, and then we're done. So it's really, really fast, really efficient, and really smooth. This is my typical thought process, how I'm working through these issues. So if I think that we're in an acute phase and we're just working with an acute overuse tendonitis, it's the standard treatments that, we're all familiar with: rest, NSAIDs, steroids. Sometimes we need physical therapy. Some people are compliant with just like an exercise plan or activity modifications, or, don't do as much of this activity in the gym or whatever it is. And I don't typically need to go straight to TendoNova or PRP. But in the tendinosis phase, when we're in that chronicity and we feel like we're circling, that's when, I think it really shines. For several patients, I will try a cortisone first. I like to get a really, really symptomatic, uncomfortable tendinopathy cooled off with a cortisone shot first, and then follow it up with my tenotomy procedure, maybe like, 2 months later or 3 months later. Because I found that the folks who are really, really flared and in a lot of pain, and then we go in and do the procedure, they're still in a lot of pain. So, getting that to cool off a little bit, that's how I prefer to do it, and then get them started with the therapy. And then go ahead and do, the tenotomy procedure, and then sometimes we'll add the PRP. Whenever I get an MRI, and this kind of goes back to one of my earlier slides when I'm selecting patients, when we're identifying the exact cause, I like to know exactly where on the tendon the problem is and where, what exactly I'm working with. And I use a lot of ultrasound in my practice, and I use a lot of diagnostic ultrasound, but sometimes it's nice to just see the 10,000-foot view with an MRI to see everything that's going on, so I'm not missing anything while we're doing this. And when I find a tendon that's chronically inflamed and has interstitial tearing as part of it, I'm almost always recommending PRP. And in those cases, I don't put any steroid in the beginning phase. So I'll cool it off with NSAIDs, no steroid shot, get them into therapy. And then we're either going to do TendoNova by itself or TendoNova with PRP. In the calcific tendinopathy, I do like the cortisone to get the ball rolling when we start off in the beginning, just to cool it off. And I do those all ultrasound guided. So wherever I see that calcific lesion, then I will try to pepper it with the cortisone, send them to therapy, and if they don't improve, then we're going to do TendoNova, and we're just going to debride it and get moving. And then you can always couple that with PRP. So a lot of success by doing it that way. And honestly, that's just been a process of trial and error, just trying folks where we just go straight to this or straight to that. And, let's try with this and try with that. And this is just anecdotally over, dozens of cases. So. All right. So, what are the benefits to TendoNova in practice? Like I said in the beginning, this is just part of my toolbox. I like to, and Ben and Kelly will roll their eyes because I used this analogy before, but this is kind of like how I choose what golf club I'm going to use. So, there's times where I need to hit a long club, like I need to take out the driver, and we need to do that. And there's other times where I need a pitching wedge and I need to be more precise. And this is kind of how I use TendoNova. This is like my pitching wedge, right? This is how I want to like attack the pin. Very, very precise, very subtle, very smooth, super efficient. It's kind of a go-to where I know, okay, like I know I can get this and do a good job with it, and I don't feel uncomfortable because it's so efficient and so precise. And I really like how it couples with PRP because I do so much PRP for our like professional and collegiate athletes. That is like that is like the mainstay for managing some of these professional athletes. The TendoNova I think couples extremely well with that. And so whenever we have to do like um, a tendon procedure in that population, it's going to be with TendoNova. And the recovery, I think, is a little faster because the wound care is better. There's less incisions, less soreness. There's less introduction to, some of the healthier tissue where I have to get through it to get to the bad stuff. So they just get better faster. And, another side note is, we've actually, done really well from a reimbursement side with TendoNova. We've run into issues with other devices from reimbursement side of things at our surgery center. And so that's been really nice too, is just, knowing that with the TendoNova, we can do the procedure and it's really uncomplicated from a billing standpoint for our coding team. So that's very nice too. So another, just reasons why you all should consider, trying this if you haven't yet. A couple real life examples. So, this is one of my favorite cases, and anybody who works at our hospital knows exactly, this whole situation because it's, she tells everybody. But one of our employees, surgical tech, saw me doing this procedure on somebody one day and said, "Hey, I've been having some lateral hip pain. I should come see you. I've been seeing this other doctor and been getting cortisone shots for years." And she's 60, but she loves to dance, and it was really bothering her, and she wasn't able to do any of this stuff. So she came in, we looked at her. It's been going on for a long time. She's tried the therapy and she's tried injections. And so we got an MRI, and it just showed a run-of-the-mill, nothing too complicated, but nonetheless persistent, gluteus minimus, insertional tendinosis. And like I said, I've just seen it so many times where patients are diagnosed with, trochanteric bursitis, and then they're just given like they're just cortisone is just getting dumped to the outside of their hip every, few months. And that's what she was getting. It's just kind of going around and around and around. And I said, I really think that you're going to need this procedure. So we lined her up for TendoNova. I told her I think we should do some PRP with it to give ourselves the best chance for success. And we went ahead and did it. And we were really efficient. I mean, I think the cutting on that was about 30 seconds. I just looked down, saw the medius, gluteus minimus. I actually didn't do any cutting to the medius, but the gluteus minimus, you just identified it on ultrasound. Go down right to the insertion. You see where it looked pathological. I could see some tendinopathy appearance to the tendon. Started debriding it, made some cuts, put our PRP in there. At 2 week follow-up, she was already feeling better, which most people don't feel better that fast on glute tendons. Sometimes they take a little bit longer. They can be really sensitive, but she was already noticing. She's like, I could tell this was already working. We sent her to do a little physical therapy, and I kept seeing her in the OR suite all the time for other patients. So I was seeing her sooner than her 3 month follow-up because she was telling me how she was doing. But at her, officially at 3 months out, she was just phenomenal. So total complete resolution and back to all of her activities. And every time I see her, she gives me a big hug because she just loves it. So she's a big TendoNova fan. So that's, one. And then another case of just how I use it with plantar fasciitis. I had uh, this patient who came in literally crying. She was dealing with plantar fasciitis for, months and months, and it was really affecting her. And so we did all the standard things, physical therapy, NSAIDs. I had her change her shoes, work on posterior chain exercises, stretching. and activities in the modifications in the gym. It wasn't better, so we ordered an MRI. Now, I get the MRI before my plantar fascia cases because I'm looking for, is it mostly in the central cord, lateral cord, both? Are we dealing with partial tearing? Are we dealing with interstitial tearing, or are we just in tendinopathy? And so, or I should say tendinosis. And so that helps me decide if I'm going to do, PRP or not, or what approach I'm going to have, or how I'm going to actually, come into the plantar fascia, medial approach, lateral approach, whatnot. So she just had severe central cord. So we did her TendoNova, no PRP. We just debrided it, got it to loosen up, put her in a walking boot for 2 weeks, sent her to PT, changed her footwear a little bit. And my protocol is typically to have them start progressing back to normal activities at 6 weeks. And we're just working on biomechanics. So like I said, we're working on the cause for this. If we don't figure out the cause, then we may have it may come back on us later on. So we work on that, and just saw her for a follow-up a couple of weeks ago, and she's doing amazing. She's complete pain-free at 3 months out, back to the gym. So doing awesome. So just a couple success stories. I'm a big believer in this stuff, and I really like just how smooth it can be and the whole process for the procedure. So, if you haven't considered it, I think it is something that you should, add to your treatment box. It's just another really great tool. So is that my last slide? Yep, that's it. So with that, I'll turn it back to the esteemed Ben and Kelly, and whoever else is taking it from here.
Thanks so much, Dr. Eldayrie. Great presentation, and once again, we're grateful for your time and sharing your experience with us. So now, guys, we'll transition to the Q&A portion of the webinar, and I'm going to turn it over to Kelly Wharf. Quick introduction for Kelly. Kelly is our sales operations manager. She helps process orders as they come in and work with your team to get product to you on time, as well as she's our practice success manager based on her experience in illustrious physical therapist career. So Kelly routinely helps out, with assessing PT protocols and answering clinical questions. But without further ado, I'll hand over to Kelly, and she'll go through some of the Q&A for us.
Thanks, Ben. I'll try not to keep you all too much longer, but we'll go ahead and maybe do, a few minutes worth of questions here. And if you have any other questions, feel free to send them through in the chat. Let's get started with a question we have here from the chat. And it is, what is the average recovery time to full sport that you've noticed when you use this on high level or professional athletes?
Yeah, great question. It's all dependent. The key to the recovery in that level of athletes is access to resources. That is like the number one key. So, when we're doing procedures on the pros, they're getting PT like literally daily, like every practice. So they get better really fast. I would like 6 weeks, usually they're back full. Some of the collegiate kids or high school kids, it's more of like kind of standard population with just limited access. And so without somebody getting hands-on to check on them and work on this, work on that, and work on some of the tissue management or swelling or whatnot, sometimes a little longer. But my standard guidelines when I'm advising patients is at 6 weeks, I'm okay with you doing pretty much anything you want to do. I don't think you're going to make much worse at that point. We should have gotten enough of that process started. I tell patients when we're dealing with tendinopathy, they've been like doing this, like they've been going down, and then we do TendoNova, and then they're going to start going up, and that takes time. And then some people go straight up, and then some people go like the stock market, like ups, downs, and eventually they get there. But it's different per person, and some people just heal really well, and some people are young athletes. We have professional athletes on our, on our women's soccer team that are, pushing 40. I mean, that's not super duper young. It's not like an 18-year-old, so they recover differently. It's all good, but standard is about 6 weeks.
Great. Another question that we have is, will you use dextrose instead of PRP, and what concentration?
Yeah, we do use dextrose sometimes. I add that as a as a typically as a standalone. I haven't done it after TendoNova. Could you? Yes, you could. We use 5% in clinic, but I don't have any cases where I've added that on typically. I don't think it's a problem. I think the question would be, when do you want to add that on? You know, immediately during procedure or after procedure. I guess you could. I don't think that it'd be too much of an issue. But no, I haven't typically done it with the TendoNova. Most of my Prolo therapy, like what you're referring to as Prolo, most of that I do kind of as a standalone or as a supplement after a tenotomy procedure, or like after I do like calcific tendonitis and I need it to kind of get a little bit of a boost, like we just need a little boost. That's when I'll use the dextrose to kind of give us just like a little boost, because it typically is a little irritating, but sometimes not as painful as the PRP is. And so I just use it to just kind of like boost our progress. But I don't get as much of a robust response as I do with the platelets. So I tell patients, I call it the poor man's PRP. Of course I'm like, that's not true, but it's PRP is taking those healing factors directly from the plasma and with the platelets and putting it directly into the issue, where dextrose, you're trying to inflame it on purpose and recruit the blood flow secondarily. So you kind of bring those factors secondarily. So it's to me, I don't get as big of a response, but I've had great success using dextrose on some tendons where I didn't even have to do any, tenotomy procedure. So could you use it with it? Sure. I don't see why not.
Great. All right, our next question, it's a multi-part question, so I'll kind of start with the first part, but do you ever do nerve blocks or just local anesthesia?
Yeah, great question. We had thought about doing nerve blocks for certain procedures, suprascapular nerve block for like a calcific tendinopathy of the rotator cuff. Um, I haven't needed to. I just, with the local, we're good. We'll just localize the area. Um, I guess you could do it in the heel. I had a partner who was doing it for some of his tenotomy procedures, but like a posterior tibial nerve block, but it just seemed a little overcomplicated. And we typically, when you just start localizing you just do the local anesthetic right at where you're going to introduce the TendoNova, they typically do fine, to be honest with you. It's almost like unnecessary and overkill, and it just takes more time. When I'm doing procedures in clinic, like a lot of shoulder procedures, I almost always do like complicated ones. I almost do a suprascapular nerve block for those, but no, for the tenotomies, I don't typically need to. You could. I mean, it's a little extra. You can get a little extra reimbursement doing that, but I don't know that it's really been necessary for us. People seem to do fine by just localizing the tissue itself.
Great. And then the second part to this question is more about reimbursement and cost, but they asked, is the reimbursement good so that you can be profitable with doing this in the clinic versus in the ASC? And how does the cost compare to 10X?
Yeah, so reimbursement wise, it does great. So it's the same CPT codes that we use for 10X. The overhead is less. So I mean, these guys could tell you about that more, but the overhead of purchasing is cheaper than the 10X, so that's good. The billing component, like I mentioned in the presentation, is a little bit simpler. Some of the 10X stuff has run into issues with certain third-party billing companies, and TendoNova has not, just by the technology that it uses to do the cutting and the debridement. In clinic, I don't do much. Actually, I don't do any TendoNova in clinic because of just reimbursement issues. You could. Certainly, it depends on your payer mix and how you have it set up. For us, the way we have it set up in our practice, everything would be cash, and patients just don't want to do that. They'd rather just have it done. We literally just do it down the hall. It's right down the hall, so it's very easy to do it in our procedure suite. So that's our setup, but other practices do it in clinic, and that's totally fine. And it does do really well. I mean, I think the key is that you get reimbursed for the codes. The CPT codes are the same. So if your overhead is less, then you're going to be more profitable with the TendoNova.
Great. And then we'll just wrap up with one last question. What's the typical learning curve? How many cases until you're pretty comfortable with the device?
Yeah, great question. So I would say it took me maybe that first 10 is really where you're learning the ropes here, because each body part needs a different little you kind of have to figure your way. So it takes a few cases, right? So I think the first one I did, I can't remember. I think it was a plantar fascia, but I think I wanted to start with a plantar fascia because that was kind of a bread and butter that I do so many 10Xs for. I said, okay, I know this area pretty smoothly, and like I know I can work my way around if I feel uncomfortable with the device, because it does take a little getting used to the ergonomics of the device and feeling the weight of it. And then when you get your finger on the button and you push the button, that thing just, I mean, it is super efficient. I mean, it just cuts real quick. So it'll surprise you in the beginning, just how smooth it is. Just boom, it just goes right through. So that first 10, I think, and I planned a little extra time for those first few patients, and kind of prep the folks in the room that we don't tell the patient this is going to be the first time we use this device, but we tell everybody in the room is that, okay, this is let's figure out some of the quirks, because a lot of the success comes from a good setup and people handing you things when you need them at the right time, and setting up the room the right way, and positioning the ultrasound in the right spot, things like that. That's really, you set yourself up for success. So that takes a little time to figure the logistics of the procedure out. But doing the procedure, if you feel comfortable doing ultrasound guided injections or ultrasound guided anything, you can figure this out. I mean, it's really not, it's really all about guiding that needle to this precise location. And then really being specific, like I said, being specific on like what you see on the ultrasound. Like when you find that bad area of tendon, really just targeting that and trying not to introduce too much, trauma around it. Like when I'm doing an Achilles, I am extremely, extremely gentle and careful with that. I'm very precise, take my time. I'm not rushing anything. I only push that button when I know I'm in a spot that I want to actually cut. And so that first 10, I think, is really where you figure that out. But each body part, an elbow, an Achilles, shoulder, glute, they're all a little different. Hamstring, they're all a little different. So you just kind of have to play with your patient positioning and all that.
Great, thank you. That'll conclude our Q&A for today, but I just want to thank you, Dr. Eldayrie, for taking the time to speak with us today. And thank you everyone that joined us tonight. We'll be sending out a recording afterwards if there's anything that you want to watch again. And of course, if we didn't get to your questions today because of time, we'll try to reach out to you so we can answer any unanswered questions. And if you have any other questions, please feel free to reach out to your local rep or to us or via the website so we can stay in contact. But I hope everyone has a great night. And thanks for coming.
Thanks so much, Kelly. Thanks, Dr. Eldayrie.
Thanks, everyone.
Bye-bye.